our current indications for starting hydroxyurea is 3 or more hospitalizations with crisis in a 12-month calendar period. Having said that, the third point, number of days missed from school, I feel that's very important because you may not even be coming into hospital, but if you're at home or you're missing work because you're having pain, then that should be taken into account. And now, as again with more experience on our part, we would even go with two significant hospitalizations plus more missed days from school. One acute chest where you end up in ICU and you have exchange transfusion and you're quite sick would be an indication to start hydroxyurea. Patients who have abnormal transcranial Doppler screening and refuse transfusions to prevent stroke, we would try to have them go on hydroxyurea instead of transfusions with an abnormal transcranial Doppler. Some of our patients have very, very low oxygen levels, and it's a very small number. They really do struggle to stay awake during the day at school, and we have started those. There's a small number of patients with very low oxygen levels, and then the two last things tend to come together. The patients with very, very low hemoglobins under 70, we would consider starting on hydroxyurea. Those tend to also have, some of the above tend to be all together. They tend to have crisis.
How are you tested for the low oxygen levels? Is that
the oxygen saturation, the little finger. And then we know what happens overnight is some of our patients, many of our patients now are getting sleep studies. So they go to sleep and we just monitor them. They come into the sleep lab and get monitored overnight, and some of them are desaturating when oxygen is going very low while they're sleeping. So those patients we could consider hydroxyurea.
So is that something that's only tested if, like, when you're having like a VOC episode in the hospital, or is
every clinic visit you get a big an oxygen saturation done on your finger. You're probably not aware that it's being done, but when you're getting your height and weight and your blood pressure and so on, there's a little thing that goes on the finger, and we don't announce that it's normal, but if it's abnormal, then we make a note of that and we'll say something. So those are the sort of clear-cut indications that not a lot of people will argue about. The second set are potential indications. So most patients with SC disease are very healthy and have intermittent problems, perhaps, but we have an occasional SC patient who has very severe disease, always having a crisis. They can get hydroxyurea and it works for them the same way. Patients who have high conditional TCDs, so some of you, the younger ones, people with younger kids will know what TCDs are. It's an ultrasound of your brain, which looks to see if you're at risk for stroke. And you get it once a year, and if it's normal, you get it next year. If it's abnormal, meaning very high, over 200 centimeters per second, some of you might be aware of this if you've had that, then we recommend transfusions. And then there's a group in between who is not abnormal, it's not normal, but those, we call them conditional areas, we may suggest going on hydroxyurea on those patients. People who have silent infarcts on screening, so we've just completed a silent stroke study at Sickle Cell, and it's an international study, and we were part of that, and it's looking like in patients, if you screen healthy, otherwise sickle cell patients, it looks like about 1 in 5 patients have tiny little strokes in their brain that don't affect them in terms of motor-wise, they're not weak, or they don't have a limp or anything like that, or speech is not affected, but academically they might have difficulties, and they have these tiny strokes in their head. Some of those patients we would offer hydroxyurea, because at this point we don't really know what would be the best treatment for those patients. This study is being analyzed right now, and they will tell us whether transfusions in those patients are recommended. And then there are a few patients who, these 4 and 5, 3 and 4 might actually be going together. Kids who over time, as they get higher up in school, the academics is more and more difficulty with academics. And when those come to our attention, we do an MRI, and they probably have strokes, and so we could offer them. And if somebody had poor growth and development, we might offer them hydroxyurea if we connect with the other causes, and if they're not another issue. So starting a patient on hydroxyurea, we review the history. We look for evidence of organ damage. This is all done as a routine, which you're probably not aware of. The TCD velocities, you would know, we check the urine, we do the oxygen saturation, and that's why an academic performance. I ask, as the kids come in, ask, how are you doing in school? It's not I'm being nosy. It's part of a good history, how the kids are doing in school, and sometimes I ask parents, can you bring your school report when you come in? Actually, everybody, it would be nice if you could bring your school reports when you're coming to the clinics, and then we can review them, and there are things that we can do to help advocate for kids in the school with poor academic performance. We document growth and development and get a good baseline physical exam prior to start. So we discuss with the parents. We actually discuss some of the studies that you've seen just before, a little while ago. The risks, which I'll go through, the theoretical long-term risks, expectations for monitoring, so we have a clear understanding. If I prescribe the drug, this is what you're going to do in terms of blood work. And then there's some literature we have copies that we'll give you. So on the Sick Kids website, it's called aboutkidshealth.com. About Kids Health is all one word.com. There's several. You can go there and get a lot of information about a lot of things. And slowly I'm getting some sickle cell information in there as fast as I can get it written in between everything else. And then we give you an OHIP requisition to get the blood work done closer to home for people who live away from sick kids and have it taxed in. So the short-term and medium-term effects. Any drug can give you nausea and vomiting. If you take it on any medication on an empty stomach, you can feel like throwing up after. So ideally, when you use drugs on an empty stomach, the absorption is better. But if you're getting nausea, we say take your dinner and then have it. Some patients get a skin rash up front, and if they persist with the drug, the skin rash goes away. We've had, because of the type of drug it is, we've had a few girls, the boys, it doesn't matter, who their hair gets thinner. So it's not hair loss to the point of big chunks coming out and big patches in your hair, but the hair may not be as thick a head of hair as it was. So for the boys, most of the boys, it doesn't matter, and the girls. When you balance, again, you're balancing risks and benefits. If your hair thins out a bit, but you're staying out of hospital and staying healthy, then you're probably going to want to continue the drug. And then one thing we often, I'm guilty of, forget to mention to families is that you can get increased color at the nail beds, a darkening of the nail beds when you're on hydroxyurea. And
at first or
no, as you take it after a while, and it tends to stay. And I'm guilty of forgetting to tell parents about that. It doesn't do anything to the nails. It darkens the nails, but in terms of nail strength, the nails don't drop out or anything like that. The long-term effects, and I bring this up because, but I want to make it clear. So people worry about hydroxyurea that it will cause cancer. The class of drugs that hydroxyurea is from, this class of drugs, some of them have been shown to be associated with cancer long-term. Hydroxyurea itself has not been shown to cause cancer long-term. So when sometimes you bring it up to patients, they're kids in hospital all the time, missing out on school, and they're missing out on work because they're in hospital with the kids and losing jobs, etc. And you bring up hydroxyurea, and patients say, well, on the internet it says they could cause cancer. And then I say that there's no evidence that hydroxyurea itself causes cancer. But again, it's a balance. You have a child who's sick in the ICU with a tube down his throat, trying to breathe for him. We just had a little guy come out of hospital, spending a month in the ICU practically. And when he comes to clinic on Tuesday, he's going to hear about hydroxyurea again and again and again, and hopefully they will start. Because you almost lose somebody, and if you're worried about maybe cancer in 20 years, when there's no proof, and that's the reason you're not giving the drug, you're not balancing risks and benefits properly. So the blood work that we do a number of blood tests. upfront before starting. On girls who could get pregnant on childbearing age, if they're sexually active, they should be on oral contraception, or women should be on oral contraception while they're on the drug, because you don't want to be on any medication when you're trying to be, if you get pregnant. So one of the things that we don't do is we don't do beta HCG testing every time you come to clinic. We ask the girls if they're using any method of contraception, or and we rely on them to tell us. In which case, if they are sexually active, we would refer them to the gynae clinic to get counseling and go on contraceptives. And then every 3 months, we have a series of things we do. So the first, what you do at the blood clinic close to home is a CBC, a blood count, and a white cell count. We start at a lower dose, and then about 10 to 20 per kilo per day. Everything on pediatrics is based on per kilogram. The adults may start at a standard 1,500 milligrams or something like that. And then we gradually increase the dose till we get a steady state. Steady state could be, usually we wouldn't go above 30 milligrams per kilogram, and a steady state could be at the point where the patient is no longer coming into hospital or not having a crisis at home. Don't expect as soon as you start taking the medicine that you'll get immediately you won't be having pain. It takes about 3 to 6 months to remember working on those developing cells. So you have to have enough developing cells exposed to hydroxyurea to have the effect. So you see the effect by about 6 months. Okay, but some parents tell us before, but by about 6 months. So if you get a crisis within a month of starting it, don't be discouraged and don't stop it. As we're following patients along and their blood counts are dropping, if we get to a point where the count keeps dropping, we will, at a particular dose, we would go back to the last dose that the patient was on, that they were having a good response on. A lot of this is just a lot of nitty-gritty about monitoring and so on. So, in summary, hydroxyurea appears to be an ideal drug for sickle cell disease. And there was a recent consensus meeting in the US where all the docs and all the researchers from all over North America went to this conference. It was just on hydroxyurea and sickle cell disease, and at the NIH. And what came out of that was that hydroxyurea is not being used enough in patients with sickle cell disease. One of the things I would like to do is, if any parents in the audience would like to say their child's response, or any adults, their response on hydroxyurea. Would anybody want to say something? Yeah.
Yeah, okay. Oh,
okay, her son's
yeah, Tina started taking the hydroxyurea when she was 10 years old, and before then she would go to the hospital at least 5 times a year. And then there were a few times when she would just get a little ache here and there. So any school report she would miss about over 20 days of school, 30 days usually. And when she started taking the hydroxyurea, it drastically reduced, and the few times that she was in hospital, you could see that there was a stressor that wasn't properly managed. That's why she would end up coming in. And then the brother also started taking it, I think 3 years ago, 3 or 4 years ago too. And he's responding very well too. Rarely goes to the hospital. And the only thing that, the time that he's taken, he's only been in the hospital because of, he had a flu, and stayed home thinking it's just a cold, and then he ended up being full blown. Yeah, so otherwise, it's been.
Any negative effects that you noticed?
Tina's hair is thinned out a little bit, and her nails are dark. But with him, I don't think there's any. Oh, and they eat well now. Yeah.
Okay. Yeah, my daughter started taking hydroxyurea last year, April. And the first thing I noticed was that she was looking healthier. Because then, before then, like you said, like that was just, she had a rough year prior to that. Before it wasn't that bad. A year prior to that, she had a rough year, often on the hospital, like every other month. Then she started on Hydroxyurea. The pill phase started changing. She started looking healthier and more robust, lots of energy. And then they did, the modification, increased the dose and a little bit. And she's been stable since then. She has not gone to the hospital since April. Well, sorry, the last time was, she had just taken it for 3 months. She was admitted in July last year for 5 days. And since then, she's been well. She hasn't had anything. She has had pains here and there 1 or 2 days, and it goes away. And she's been responding very well to that. And the only, until that now, I don't know, I didn't even know that that was part of it. Her fingers were darkening, and I was worried. I kept checking, and I checked the sisters, and I said, why is it so? Now I know why. So I was just, so that's the only negative side effect that I have. Yeah.